So my talk is in the session of hypogonadism, but it's strictly not a hypogonad talk. But since I had to enter this session of hypogonadism, I just included hypogonadism in the topic as well, although I have a total of 2 slides on hypogonadism, because erectile dysfunction in diabetes is hardly a hypogonadal problem, and we'll just discuss that in the next 10-15 minutes or so. This incidentally is something that all of you will be required to treat in your practice. Unlike hypogonadism treatment per se, where you would probably refer your patients to Dr. Unni, erectile dysfunction is something that all of you will be treating yourself, and this then becomes a much more pertinent talk from your clinical point of view. Now, there are some complications in diabetes which are overt, and this photograph is taken from an elephant farm in Thailand, and as you can see, there are certain things that you know, it's sort of like the elephant in the room. You cannot get away from the fact that your patient will have peripheral vascular disease. The whole controversy with SGLT2 inhibitors, some kind of SGLT2 inhibitors, that is that they cause amputation. So this is not something that is sort of, hidden or anything. But there are some complications which are hidden. I'm not sure whether Van Gogh had been thinking of erectile dysfunction when he painted this, but this is something that is not probably often talked about. In fact, prior to 1991, erectile dysfunction was actually by and large the forgotten complication. It was regarded in 1991 as the most neglected diabetic complication. There was no known pharmacotherapy, and that, as you know, is the primary reason why people will talk about a complication. Unless you can do something about the complication, you will not talk about it. Prior to the incretins, no one talked about glucagon. Prior to any kind of molecule that produces an effect in that complication, you do not talk about. How many of you knew that there was a normal ejection fraction heart failure before the SGLT2 inhibitors came on board? So if you have something to do about a complication, you start to talk about it. And before 91, no one really talked about erectile dysfunction, simply because you could not do anything about it. It was generally believed to be a psychogenic problem. The couch, that is, I'm not talking about the casting couch, I'm talking about the psychiatrist couch, is better than pills. But now we know that it is a result of microvascular changes and endothelial dysfunction. Specifically, we can do something about this problem. We also know that to some extent hypogonadism does play a role, and as I told you, I will have a total of 2 slides which will discuss hypogonadism in erectile dysfunction. Now this is then the entire gamut of the pathophysiology why hypogonad males will have erectile dysfunction. Diabetes will cause poor control, and that causes malaise. Balanitis can cause pain. Add to that the anxiety and depression, and these patients actually have more chances of having reduced libido. Diabetes by and large is a vascular problem, and so atheroma of the ileal or pudendal arteries or the problems in the corpus cavernosum smooth muscles can cause erectile dysfunction per se as a structural problem. And finally, you have the autonomic neuropathy, which causes problems in both the sympathetic and the parasympathetic, which causes erectile failure. And as a question was put up, it can actually per se also cause ejaculatory failure in terms of dry retches or a reverse ejaculation. All these, in addition to the fact that these patients might also be on drugs like beta blockers, and many of them will also have an alcohol and cigarette issues, makes erectile dysfunction a fairly common problem in diabetes. It is commoner with advanced age. Cardiovascular disease and erectile dysfunction actually has an association, because remember, both are because of endothelial dysfunction. Also, there is some association clinically of erectile dysfunction, the problem of allowing which of your patients to have sexual intercourse, and whether it would produce heart diseases, and we will quickly have some scenarios at the end. Smoking increases the relative risk by about 100%. Moderate alcohol intake actually protects, but extensive alcohol abuse can also worsen the problem. And lastly, the quality of life becomes a very important issue in endothelial dysfunction and erectile dysfunction. 62% of people who have clinically significant erectile dysfunction actually report to have depression. Now, assessment, you need to find out whether the problem for the patient occurred gradually and is progressive. Remember that a sudden onset erectile dysfunction is almost always psychogenic. A general waxing and waning is what you would expect in your diabetic erectile dysfunction. Earlier, the erection would be normal, but the patient will not be able to sustain it. So you have to make these small, these questions are specific questions that you need to ask. Just saying that I am not having an erection is not enough. And lastly, loss of libido, remember, can also be generally psychogenic. So you have to differentiate between libido and the erection. Libido is the desire, erection is the actual bodily action of erection. A libido loss is almost always psychogenic. There is very little organic causes which will cause loss of libido. Physical examination, you need to rule out other features of hypogonadism. As Dr. Unnikrishnan has shown you, some of these patients will walk into your room and you will know that, okay, this patient has got hypogonadism. Some of them will need probably more extensive investigation. The external genitalia are important. If you have phimosis, then that could be the reason, the pain could be the reason why your patient is having erectile dysfunction. Testicular volume, as again Dr. Unnikrishnan has told you, if the testes are small and soft, you're probably looking at a hypogonadotropic hypogonadism. Conversely, if they are firm to hard and small, then you might be looking at a Klinefelter patient. Investigation, a serum testosterone, prolactin and LH. Assess the cardiovascular status. Always remember to do at least an ECG in a patient who has come to you with an erectile dysfunction. Not only it will affect the way you will treat your patient's erectile dysfunction, it also can have a sort of a common soil hypothesis, because people who have endothelial dysfunction will have erectile dysfunction as well as heart diseases. So you cannot miss out on an ECG for these patients. And of course, you need to assess the glycemic status. General advice, psychiatric counseling helps. It is generally not required. Many of your patients will actually be married for years. But if you think that the patient has got severe associated anxiety and relationship issues, ask for a counseling. Drugs that may cause erectile dysfunction needs to be looked at and if possible removed from the prescription. Explain that these patients will require long-term treatment. Diabetic erectile dysfunction does not generally go away with time. Now, in the past, the treatment principally consisted of intracavernosal injections, and this was supposed to be the state of the art at that point of time. Phentolamine, papaverine, and alprostadil all have been used as an intracavernosal self-injection. The problem obviously is that it lacks spontaneity. When a patient who is using these therapies need to have a sexual intercourse, and needs to go and inject himself and then wait for the medicine to work, there is no spontaneity. There can be local pain, priapism, and fibrosis. And for obvious reasons, the discontinuation rates are very high for these procedures. Transurethral alprostadil has also been tried. It can cause some local pain, but some people prefer this over injectables. Vacuum devices were very popular in the 1970s, but there are issues, there are acceptance issues. They are uncomfortable and they might have problems in ejaculation. Penile prosthesis was at one point of time the most popular procedure for treating erectile dysfunction. These patients could use an inflatable or a semi-erect penile prosthesis. It could cause surgery. They can be malleable or inflatable. There is some issue of post-surgical infection, erosion, or device failure, and the quality of erection is obviously not the same. As a footnote, most men who had gone in for a prosthesis, the female partner actually claimed better satisfaction than the male partner. The quality of erection for the males was not very good. Before the phosphodiesterase inhibitors, the only oral agents that have been really tried were amyl nitrate and apomorphine. Not much data on that. There was an erection which lasted about 20 minutes after the drug, but there was some serious abusive potentials, and amyl nitrate was never actually very popular as an erectile dysfunction treatment. And then came the phosphodiesterase inhibitors 5, and this basically changed everything. Now, sildenafil was actually picked up by serendipity. People were not really looking at erectile dysfunction medicine. In 1992, Pfizer started a phase 1 and phase 2 clinical trial for a new cardiovascular drug, which they labeled UK 92480. At the end of the trial, most of the trial subjects, they refused to return the unused tablets because they said it had improved their sexual life and their previous erectile dysfunction had actually resolved. Pfizer obviously got very excited with this. The first study with Viagra showed that there was an increase in penile rigidity following visual stimulation in 12 men with erectile dysfunction of unidentified causes. Viagra actually went on to become the most, not one of the largest, the most largest money earner in the pharma industry. By the way, there is actually no record of how well it did in that cardiovascular trial. That cardiovascular trial was never published, so we really do not know what happened in that first trial. But we know what it does to erectile dysfunction. In 1998, the clinical trials are of academic interest actually. 532 patients, erectile dysfunction of mixed etiology. They found that 69% had successful intercourse as compared to 22% placebo. Diabetes, 65 to 70%, hypertension, 70%, spinal cord injury, 76%, radical prostatectomy, 40%. Radical prostatectomy is one of the most difficult patients to treat in terms of erectile dysfunction. They are routinely resistant to any kind of treatment, and it is actually really gratifying that 40% of these patients actually have improvement with sildenafil citrate. 52% patients on all these trials across the board insisted on continuing with sildenafil after their studies were stopped. The only adverse effects are few and far between: headache, flushing, dyspepsia, abnormal vision because of phosphodiesterase 6 inhibition in the retina. But side effects are very few and far between, and they rarely cause discontinuation. The cost-benefit ratio obviously is much higher for the patient in terms of benefit. There are no known factors, however, that why some people would actually not respond so well. That is not related to the severity of the autonomic neuropathy, it's not related to the severity of the endothelial dysfunction, but we know that patients who have had a long-standing erectile dysfunction generally have a worse outcome, and there is some role, as Dr. Unnikrishnan has pointed out, hypogonadism actually can prevent sildenafil from working. And this study they looked at 120 type 2 diabetic patients with erectile dysfunction who did not respond to sildenafil, compared them to 100 patients who did respond to sildenafil, and they found that the testosterone levels were significantly lower in patients who were not responding to sildenafil. After 2 to 3 weeks of treatment with testosterone replacement as well, their testosterone levels rose from 6 to 14, and all these patients actually experienced a better effect of sildenafil after they started on testosterone. So that means that if your patient is not responding to sildenafil, it might be a good idea to look at their testosterone level and start co-administration of testosterone along with your sildenafil, which can be continued. Now, what is the cardiovascular risk that we talk about? Does sildenafil per se increase risk of cardiovascular events? There is this feeling outside that if you actually give sildenafil, you are actually increasing the cardiovascular risk. There is no reported cardiovascular risk attributable to sildenafil, remember. It does not alter any kind of ECG changes or ventricular repolarization. But does resumption of sexual activity increase the risk of cardiovascular event? That is a more important question. If your patient is already having a borderline heart disease and then you give him something which actually increases his sexual activity, it can actually push the patient into having the first acute coronary event. Restoration of sexual activity may cause an ACS. The risk stratification, there is a Princeton protocol. If we have time at the end, I have the Princeton protocol here, and you can actually decide that this is a patient who might have a heart attack if you sort of increase his sexual activity. And there is a protocol in place. But remember, a patient who is already doing a 20 minutes brisk walk daily is not going to have a heart attack if you allow this patient to have sexual activity. This itself actually rules out significant cardiovascular disease in these patients. The relative risk of acute coronary event 2 hours after sex is 2.5 without a history of coronary artery disease and 3 with previous MI. So even in people who do have a heart disease, it's not very likely that these patients will have a heart attack following a sexual activity. But do you need to do a cardiovascular evaluation before prescribing these medicines? And that becomes an important question. Now, if your patient is a 75-year-old and he desperately wants for you to prescribe sildenafil and you give it, and in 1 week's time the patient comes up with a heart attack, I'm sure you'll get some of the blame. So, do you need to do a cardiovascular evaluation before you start these medicines? Yes. However, as I told you, if the patient is healthy with no previous history of coronary artery disease, it's your choice. If the patient is already walking 20 minutes a day, then and covering 1 mile in that 20 minutes, you do not need any kind of test. This patient is actually okay. Any other comorbidities, hypertension, dyslipidemia, maybe you should test. Other features suggesting of endothelial dysfunction, clearly yes. If your patient already has significant macroalbuminuria, dyslipidemia, hypertension, then probably yes, you need to. How extensively do you test is also something that the jury is out on. Now, you might say that I will probably screen for heart diseases, but what tests will you use to screen? No one is really very sure. At least do a baseline ECG. At least do not miss a baseline ECG problem. But it might be a good idea, if you are not very sure, to also ask the patient to undergo TMT. Now, do you advise phosphodiesterase 5 therapy after a PTCA and CABG? How many of you, the patient has recently undergone a bypass and he comes and asks you, can I take Viagra? How many of you would say no? How many of you will say yes? The answer is yes. Why else did the patient undergo the surgery? The surgery has cleared him of the block. He cannot have angina after that, or it was a really bad surgeon otherwise. So if your patient has undergone a CABG, this is actually a good candidate to, allow them to have this medicine, okay? Post-procedure men are rarely symptomatic, remember, and they do not require nitrates, they do not require coronary vasculitis, so they are actually a good set of people to have these medicines for. Now, sildenafil and nitrates do not mix. Remember this. This is something that is sine qua non. This you cannot slip upon. If your patient is on nitrates, you do not give them sildenafil in any form, because both act through the nitric oxide pathway. They can cause vasodilatation and severe hypotension. Remember also, and this is scary, nicorandil also does the same thing. And how many of you remember nicorandil when you are prescribing sildenafil? Remember that do not prescribe nicorandil along with sildenafil either. We all remember nitrates, but we tend to forget nicorandil. So, 1.5 minutes, I think I'm okay. Suppose a patient was earlier on nitrate therapy, and now it has been stopped by the cardiologist. When would you give the Viagra tablet? This is a question that the patient will ask you. I was on nitrates, my doctor has stopped the nitrate, when can I take Viagra? Long-acting nitrate should be discontinued at least 1 week before starting the therapy. That's a simple question. But how about this? A patient who was already on sildenafil is now admitted with an unstable angina or an acute MI. What do? You cannot ask the cardiologist to, wait. What will you do? Do you allow nitrate therapy? It's not in your hand. Your cardiologist will take a decision. But remember that nitrates might be given 24 hours after the last dose of sildenafil. Unlike long-acting nitrates which work for 1 week, sildenafil only works for about 24 hours. And you can actually give nitrates. Patient has been advised to carry sublingual nitrates in his pocket, SOS. All right? You have these patients who have a strip of sorbitrate in their pocket. The cardiologist has said that whenever you have pain, just put one under your tongue. Your response? What will you do about this thing? Sildenafil is contraindicated in these patients because you do not know when your patient is going to take the next nitrate. And he will obviously not remember when he has taken sildenafil. Do not give sildenafil to these patients. I'm sorry, I'm almost done. But remember that nitrates usage is actually coming down, and it's probably not a very important question. But patient asks whether nitrates may be stopped. The patient says, I desperately want to take Viagra. Can I stop my nitrates? It is not your call. You cannot stop it. But remember that emphasis is actually shifting away from nitrates. It is only for symptomatic relief. Beta blockers and ACE inhibitors are taking over. But the answer is that you send the patient back to the cardiologist and ask whether they can stop the nitrate. All right? This is all just routine things. The window of opportunity after a sildenafil tablet is about 4 hours. 50 to 100 milligrams per day is what you give. Should not be repeated on the same day. Do not allow your patient to take more than one tablet the same day. Remember that it is not an aphrodisiac. It does not improve libido. Sildenafil will only work when there is a psychological stimulation for sexual activity. It is not going to improve the desire. It is not going to improve the libido. Tadalafil and vardenafil are also available. Tadalafil is actually fairly commonly available. The advantage of tadalafil is that you need not plan the sexual activity too much, because tadalafil works for 2 to 3 days. So you do not need to take the tablet 1 hour before the intercourse. The patient can take it twice a week, and that works equally well. So there is better spontaneity in his life, and most people love tadalafil over sildenafil. And this then is my last few slides. This is the Princeton protocol for risk stratification of erectile dysfunction and coronary artery disease. The question is, for a patient who is standing in front of you, what would you advise him for sexual activity? The low risk group are people who have asymptomatic CHDs or risk for CHD, controlled hypertension, mild stable angina, post-successful CABG, uncomplicated past MI, mild valvular disease. These patients, you do not need to ask the patient to be careful. These patients can have sexual activity whenever they want. The intermediate or indeterminate risk are people who are not yet in the low risk or the third high risk group. These are patients where you need to evaluate them and then say that, okay, these patients fall in the first group or the third group. First group, they are fine. Third group, they are not fine, and this is the third group where a patient has unstable or refractory angina, uncontrolled hypertension, congestive heart failure, recent MI, high-risk arrhythmias, hypertrophic obstructive or other cardiomyopathies, and moderate to severe valvular heart disease. These are patients who should be abstaining because the risk for sexual activity is far higher in these patients. I'll stop here. I'm sorry I overshot my time. If there's any questions, we can.